Okay, so let's continue with atherosclerosis, which is one of the outcomes of hypercholesterolemia. Atherosclerosis is a type of arteriosclerosis, which in general means a hardening of the arteries that normally are elastic so they can store the energy of the pumping heart. In the case of atherosclerosis, a lesion forms in the inner layer of the intima of the vessel wall. Most important elastic arteries are the aorta, as you know, and its branches, the coronary arteries that supply the heart itself, and also the larger vessels supplying the brain, as you can see in this diagram. The number means the order of frequency. So you see the most frequent one is the abdominal aorta and the iliac arteries. Atherosclerosis develops slowly and without any clinical manifestations, and this is important, for as long as 40 years. So the patient is not aware of the problem and does not make any effort to control all the risk factors that he could modify, like the diet, sedentarism, or hypertension. Also, diabetes is a risk factor if it's uncontrolled. The problem the patient is exposed to is life threatening. You have, for example, if it affects the heart, it's the ischemic cardiopathy, strokes for the brain, or venous insufficiency due to damage to the veins. All right, so here we have a graphic that shows the total deaths due to atherosclerosis in Spain between 2005 and 2017. The disease decreased quite a lot in the first years, probably due to two factors. One are the actions of the National Health Service that made an effort to lower blood lipids through advice and the most used drug, which are statins. We'll see if we can talk about this in the seminar. And the other factor is thanks to the awareness of the public about this silent killer. So, uh, information about a disease from the side of the patients is always very important so they understand why the doctors or the therapist does what he or she does. And also you can see from 2014 the number of cases get steady. So there is no more reduction. We don't really know all the underlying causes why some people develop atherosclerosis and other people don't. But there are several risk factors identified, being the most dangerous one hypercholesterolemia. When checking risk factors, always remember to differentiate those that you can modify from those that you cannot. That's important also when you answer to your essay question in the exam. Besides high LDLs and low HDLs, which are evident risk, have in mind that diabetes and inflammation are very important. You already know that C-reactive protein denotes that inflammation is present somewhere in the body. A cardiologist that we will listen to in the seminar gives much importance to inflammation in relation with coronary artery disease. We'll see it later. As it is logical, the clinical manifestations of atherosclerosis will depend on how badly a vessel is affected and what tissue or organ that vessel is supplying. The atherosclerotic plaques may narrow a vessel very slowly but steady and produce ischemia that is felt when more blood is demanded. Especially, well, if you think in your heart, the probabilities of feeling ischemia are when you make an effort. But a problem associated with the atherosclerotic plaques are if they break, because then a sudden obstruction may happen. When the plaque breaks, the endothelium is damaged and the platelets will build up a thrombus, because for the platelets there is no difference between uh, uh, plaque breaking or an hemorrhage. So they try to stop it, right? Then that thrombus, due to the platelet aggregation, will further obstruct the vessel. If that thrombus detaches, and that's more probable when there is inflammation, it becomes an embolus that will travel until getting stuck in the vessel that is becoming more narrow as they branch out, and it may cause an infarct, that is a total occlusion of the vessel. Also, the damage of the wall of the vessel may lead to another problem we'll see later, which is aneurysm. And you'll see it can be very dangerous. Okay, this map shows you how atherosclerosis develops. And it starts the map here in the green boxes. You'll see the risk factors and increased tendency to arterial endothelial damage. The resulting endothelial injury starts as a chronic inflammation process, which is responsible for endothelial dysfunction, and there will be three outcomes to this. You have them in three different colors: yellow, orange, and light green. First, you have increased permeability, yellow, increased leukocyte adhesion, orange, and increased platelet aggregation in light green. Going back to the yellow boxes, they show that due to an increased permeability, LDLs will deposit in the vessel wall, and this will trigger inflammation that will later on contribute to the formation of a fibroatheroma. In the light green box, you see that the injured endothelium also triggers platelet aggregation, and this will contribute later on to the formation of an atheroma. Okay, so if you go back to the orange boxes, you see that leukocyte addition will make monocytes move out to the from the flow into the wall of the vessel. As they move out of the blood, they become macrophages, and these macrophages will phagocyte LDLs and become foam cells. If this is kept like this during much time, then a fatty streak will form, and this will have as an outcome the formation of an atheroma. If LDLs contribute then to uh, change this atheroma into a fibroatheroma. In the case that fibroatheroma calcifies, then it's more prone to rupture and to cause what is the aneurysm, we'll say it later, or an emboli, which is very dangerous. But if it doesn't break at this stage, it will cause thrombosis, which is narrowing of the vessels, further narrowing. In the case of affecting coronary arteries, this is going to create unstable or stable angina. We will see these conditions in the heart lecture. But the effect is an ischemia, and the clinical manifestations will depend of what artery is affected by the ischemia. For instance, if it is the renal artery, it's going to cause chronic renal failure. If the peripheral veins, it's going to cause claudication. If that happens in the central nervous system, may take you to a stroke, or in the coronary arteries again, it will cause myocardial infarction. This image is showing the evolution in time of endothelial dysfunction and how an atheroma first and then a fibroatheroma grows in the vessel wall. This is a short movie on how cholesterol and atherosclerosis are related. You'll have this video.
Atherosclerosis is the buildup of fatty deposits, including cholesterol, in the wall.
Okay, we will briefly review a couple of more conditions that involve blood vessels. The first one is vasculitis. The mechanisms of vasculitis are not well known, but available evidence seems to point to an infection or a defective immune response that will trigger an inflammatory process that then damages the wall of the vessel. If such damage affects the vasa vasorum, which are the tiny capillaries that nourish the wall of the vessel, then necrosis of the wall of the vessel may result. Vasculitis may also be the outcome of a disease called, any inflammatory disease, but especially lupus that you already know. And in that case, we talk about secondary vasculitis because you don't have an original problem in your vessels, but you have a disease that is causing injury to your vessels. This is why it's secondary. So vasculitis may affect any type of vessel anywhere in the body. So any organ or tissue may be affected and causing a wide span of conditions. But besides that, fever, myalgia, arthralgia, malaise are some of the general clinical manifestations that can be present in vasculitis. All right, then the second condition we have to talk about are aneurysms. Aneurysms occur when an artery's wall weakens and causes an abnormally large bulge. This bulge can rupture and cause internal bleeding, which is a very, very severe condition. The exact cause of an aneurysm is not clear, and we know there are certain factors that strongly contribute to the condition. Also, it is quite common in the aorta, especially the abdominal aorta. And this is because this is an artery directly exposed to the pressure developed by the heart. We have two kinds of aneurysms. They are classified as true aneurysms, where the blood remains within the vascular compartment, but the wall of the artery itself is enlarged but intact. So the wall dilates, and this is perturbing the laminar flow of the blood. Okay? So when you change the flow of the blood from laminar to turbulent, that will cause great damage to the endothelium. Because the particles contained in the blood, like leukocytes, erythrocytes, platelets, and all the other components, will be constantly tapping on that endothelium, and at the end, they cause inflammation and erosion of that endothelium. The case of a pseudoaneurysm or false aneurysm is different. Here, what we have is a dissection of the inner wall of the vessel, and an hematoma forms. That is blood that gets stuck there. In this case, only the outer layer of the artery is preventing the blood to escape out, an hemorrhage. So the wall gets damaged, in this case, from the beginning. It's not along the time. As you see here, you have the description of different types of aneurysm. Berry, fusiform, and saccular types are classified as true aneurysms, while the dissecting aneurysm is a pseudoaneurysm or a false aneurysm. But don't get confused with that. False aneurysm is more dangerous, because while the three first are dilations of the wall of the arteries, the fourth one is a severe affection of the wall that, if it breaks completely, will cause death really, really fast due to a massive internal hemorrhage. Uh, if that happens in a cavity, like the abdominal cavity, there is room for much blood, so there is the hemorrhage is going to be very, very fast. And two of the most contributing factors to the development of an aneurysm are atherosclerosis and hypertension. We'll see hypertension the next lecture following this one. Uh, the two factors may be independent, so you can have one and not the other, but quite often they are related, in the sense that if you have atherosclerosis during an extended time, you will finish by having hypertension, because the heart is going to adapt uh, to the new situation, and while your arteries are getting less and less elastic, and that's what causes hypertensions. Um, both of these conditions can be modified by a lifestyle change or drug therapy. But you know that always, first thing you have to try is avoid uh, everything you are doing wrong, to see if you can control the condition. Aneurysms are very difficult to diagnose based on the symptoms and signs, because those can be very, very variable, and they can be not present at all until the vessel breaks. This puts the patient as a very, very difficult situation, life-threatening situation. For instance, imagine you have a male patient older than 60, heavy smoker, obese, following a bad diet, with a blood pressure of 160, 110, family history of vascular or heart problems, and imagine this patient comes to your clinic, and he's complaining of a sudden back pain not associated to other causes. Okay, if that happens, uh, well, don't think about hernias, vertebrae, or nerves. In first instance, you need to take this patient as a red flag. So it's going to be good to refer first this patient to a doctor, and that doctor will probably prescribe a CT scan or ultrasound to check first the arteries. Okay, you can see that patient later on. And what is the treatment in the case of an aneurysm? Well, as in any other condition, you have to modify the risk factors that can be corrected. Okay? And this requires the collaboration of the patient. And to get that collaboration in any kind of patient with any kind of condition, it is essential to provide him or her with detailed information of what's going on and how to correct it. Chiropractors do that very well, uh, well normally. Okay, as is a standard to inform their patients very well. But if this condition has evolved enough to cause that big dilation in an artery, then surgery to insert an endovascular stent graft may be necessary. In this image, you can see the technique. So you have to take the stent to where the defect is. Then the surgeon places the stent, pulls a cable, and the stent opens, and it has to be left there forever, which you will see is related to other conditions that, like endocarditis, that need for prophylaxis for any treatment, any other surgery you perform in the patient. So that's it for this part of the lecture. Hope it was useful to you. And I'll see you again after Eastern.